In biostatistics, variables play different roles, and those roles affect how you design an analysis and how you interpret results. The outcome is what you are trying to explain, predict, or change. It is the result you care about, such as a health event, a score, a time to completion, a cost, or a quality metric. The exposure is the factor you think might influence the outcome. In some settings, the exposure is an intervention, like a program or policy, and in other settings, it is a characteristic or condition, like a risk factor, a dose, an environment, or a behavior. For example, an outcome could be completed the program, and the exposure could be received reminder messages. Another outcome could be time to resolution, and the exposure could be handled by Team A versus Team B. The basic framing is simple. Exposure is the potential driver, outcome is what happens. A confounder is a variable that can distort the relationship between exposure and outcome because it is related to both. Confounding is one of the most important ideas to understand because it is a common reason results look stronger or weaker than the truth. For example, suppose people who use a new service have better outcomes. If those people are also more motivated, have more resources, or have fewer baseline barriers, motivation or resources can confound the relationship, making the service look more effective than it really is. Another example, suppose one treatment is used more often for more severe cases. Severity is related to treatment choice and also related to outcomes. So without accounting for severity, the treatment could look harmful even if it helps. Confounders are not bad variables. They are context variables that must be handled carefully so comparisons are fair. A mediator is a variable that sits on the pathway between exposure and outcome, meaning the exposure influences the mediator and the mediator influences the outcome. Mediators help explain how an effect might happen. For example, an intervention might increase knowledge, knowledge might change behavior, and behavior might improve outcomes. Another example, a staffing change might reduce wait times. Lower wait times might reduce missed appointments, and fewer missed appointments might improve outcomes. The practical implication is that adjusting for a mediator can change what you are estimating. If you adjust for a mediator, you may remove part of the exposure's effect because you are controlling for a step in the pathway through which the exposure operates. That is not always wrong, but it answers a different question, so it should be intentional. An effect modifier is a variable that changes how strong the relationship is between exposure and outcome. It means the effect is different across groups or conditions. This is sometimes called interaction because in a statistical model, you often represent it with an interaction term. For example, a program might improve outcomes more for people with high baseline risk than for people with low baseline risk. Another example, a treatment might work well for one subgroup but have little benefit for another subgroup. In operations, a process change might reduce delays in high-volume settings, but not in low-volume settings. Effect modification is not a nuisance in the same way confounding is. Confounding is distortion you often want to remove. Effect modification is a real pattern you may want to understand and report because it can guide targeting and decision-making. These roles also help prevent common analysis mistakes that come from treating every variable the same way. A frequent mistake is adjusting for a mediator and then claiming you estimated the full effect of the exposure when you actually estimated something closer to a direct effect that excludes the pathway through the mediator. Another frequent mistake is failing to adjust for a true confounder, which can make an association look like an effect. Another is interpreting an effect modifier as if it were a confounder, which can lead to reporting only an overall average that hides meaningful differences across groups. Multiple examples show why clarity matters. If an outreach program increases attendance by improving scheduling access is a mediator, and adjusting for it will shrink the estimated program effect. If baseline severity drives both who receives an intervention enterprise and who has poor outcomes, severity is a confounder, and failing to account for it can flip your conclusion. If an intervention works mainly in settings with strong implementation, implementation strength is an effect modifier, and reporting only the average effect can hide where it truly works. A practical way to keep these roles straight is to tie each one to a plain language sentence. Exposure is what you think could influence outcomes. Outcome is what you are trying to improve, reduce, or explain. Confounder is a pre-existing difference that can make groups look different even without a true exposure effect. Mediator is a step in the chain through which the exposure produces change. Effect modifier is a condition that changes the size or direction of the exposure's impact. When you classify variables this way before modeling, it becomes much easier to choose which variables to adjust for, which to examine as pathways, and which to test for differing effects across groups. It also makes the final explanation more honest. You can clearly state what was controlled for, what was considered part of the pathway, and where effects appear stronger or weaker. Misclassification happens when a variable is measured incorrectly, meaning some observations are placed in the wrong category or have the wrong value. This can happen for exposures, outcomes, and covariates. It is extremely common because real-world data are often messy. People forget details, records are incomplete, coding practices vary, and the measured proxy is not the same as the true concept. For example, an exposure like received a service might be recorded as yes when it was only partially delivered, or recorded as no when it happened outside the system. Another example, an outcome like disease present might be recorded based on a diagnosis code, but the code may reflect rule-out testing rather than a confirmed diagnosis. Misclassification is a measurement problem, not a statistical trick, and it can change results in predictable ways. A key idea is the difference between non-differential and differential misclassification. Non-differential misclassification means the measurement errors happen similarly across groups. For example, if both exposure groups have the same chance of having outcomes recorded incorrectly, that is non-differential. Another example, if a survey question is equally confusing for everyone and misreporting is similar across groups, that is non-differential. A common effect of non-differential misclassification for a binary exposure is that it tends to dilute associations toward no effect, making real differences harder to detect. In plain language, if you mix up the exposed and unexposed groups a little bit, the groups become more similar than they truly are, so the estimated difference shrinks. Differential misclassification means the measurement error differs across groups, and this is more dangerous because it can create or exaggerate associations. For example, if one clinic documents a condition more aggressively than another, the clinic may appear to have higher disease prevalence even if true prevalence is the same. Another example, if people with an outcome are more likely to recall and report an exposure, exposure measurement becomes linked to outcome status, which can happen in retrospective designs. Another example, if a new policy increases screening, you may detect more cases not because true incidence increased, but because detection improved. Outcome measurement changed as a function of exposure. Differential misclassification can push results in either direction and can even create an apparent effect when none exists. Misclassification also affects covariates, which matters because covariates are used to adjust for confounding. If confounders are measured poorly, adjustment will be incomplete and residual confounding will remain. For example, if severity is captured by a rough category that does not reflect true severity well, then adjusting for that category may not fully balance groups, leaving distortion in the estimated exposure effect. Another example, socioeconomic status, might be represented by a single proxy like insurance type, which is related but not identical. Adjusting for insurance may not remove confounding due to income, education, or housing stability. Misclassification in covariates can make adjusted models look sophisticated, while still failing to address the core confounding problem. Continuous variables have misclassification too, often called measurement error. Measurement error can come from instrument variability, inconsistent procedures, rounding, or data entry mistakes. For example, blood pressure measured with different cuffs or taken under different conditions can vary systematically. Another example, weights entered into a system can include unit errors, pounds entered as kilograms, or digit errors that create extreme outliers. Another example, timestamps can be recorded inconsistently, such as recorded at check-in rather than when the service actually began, which changes what wait time truly means. Measurement error in continuous exposures often weakens estimated associations and can produce misleading dose-response patterns because the measured dose is a noisy version of the true dose. The practical impact of misclassification depends on the type of variable and the analysis goal. For classification tasks, misclassification can reduce predictive performance because the model learns from noisy labels. For causal or associational estimation, misclassification can bias effect estimates and change whether a result appears present or absent. Examples help show the range. If a medication exposure is missing for many people because they filled prescriptions outside the captured system, exposed people may be misclassified as unexposed, shrinking the estimated treatment effect. If outcomes are detected more in one group because of increased follow-up, that group may appear to have higher outcome rates even when true rates are similar. If a key confounder is poorly measured, adjusted results may still be confounded and can mislead decision-making. Because misclassification is so common, good biostatistical practice includes steps to assess and reduce it. This often starts with operational definitions that match how data are collected. For example, instead of defining exposure as any record of service, you might define exposure as 2 or more records within a specified window to reduce false positives. For outcomes, you might require confirmatory evidence such as multiple codes, a lab result, or a combination of indicators. For example, defining disease based on repeated diagnoses or diagnoses plus medication can improve validity. For continuous variables, you might apply range checks, unit checks, and consistency checks across time. Another approach is sensitivity analysis, where you test how conclusions change under plausible misclassification scenarios, which can show whether results are robust or fragile. Finally, misclassification should be discussed transparently because it affects how confident you should be in conclusions. If exposure is measured with known limitations, the results should be framed accordingly, such as noting that estimates may be biased toward no effect or that detection differences could influence observed outcome rates. If outcome detection changed over time, interpreting trends requires caution because apparent increases could reflect improved measurement rather than true increases. If confounders are measured crudely, adjusted estimates should be described as adjusted for available proxies rather than fully adjusted for the underlying concept. This is not a weakness, it is responsible reporting. In many real jobs, the most valuable contribution is not producing a single number, but explaining what the number likely means, given how the data were measured. Covariate selection is the process of deciding which additional variables to include in an analysis to make comparisons fair and interpretations accurate. Covariates often include demographic factors, baseline risk factors, prior history, context variables, and other characteristics that could influence the outcome. The goal is usually to adjust for confounding, meaning to account for pre-existing differences between groups that could otherwise distort the exposure-outcome relationship. For example, if comparing outcomes between people who did and did not participate in a program, covariates might include baseline severity, prior utilization, and access-related factors that influence both participation and outcomes. Another example, if comparing outcomes across sites, covariates might include baseline performance, population mix, and resource levels that influence both which strategies are used and which outcomes are observed. A common mistake is choosing covariates purely based on statistical significance or purely based on what is available, rather than based on a clear reasoning process. Selecting covariates based only on p-values can lead to unstable models and biased estimates, especially when sample size is large and many variables become significant, even if they are not meaningful confounders. Selecting covariates based only on availability can lead to missing key confounders and including irrelevant variables that add noise. For example, including a variable that is unrelated to both exposure and outcome usually does not reduce bias and can sometimes reduce precision by adding unnecessary complexity. Another example, excluding a true confounder because it is not statistically significant can leave bias in the estimate because confounding is about causal structure, not about p-values. Overadjustment happens when you adjust for variables that you should not adjust for, and it can change the meaning of what you estimate or even introduce new bias. One form of overadjustment is adjusting for mediators, which are variables on the pathway from exposure to outcome. If you adjust for a mediator, you may remove part of the exposure's effect. For example, if an intervention improves outcomes by increasing follow-up visits, and you adjust for number of follow-up visits, you may control away the pathway through which the intervention works, shrinking the effect estimate. Another example, if a training program increases knowledge, which changes behavior, which improves outcomes, adjusting for knowledge or behavior can reduce the estimated total effect of training. This can be appropriate if you specifically want the direct effect not operating through that mediator, but it is overadjustment if your goal was to estimate the overall effect of the exposure. Another form of overadjustment is adjusting for colliders, which are variables influenced by both the exposure and the outcome, or influenced by causes of both. Conditioning on a collider can create an artificial association that was not present. This can feel counterintuitive, but it is a major source of bias in real analyses. For example, if you restrict analysis to people who have frequent follow-up, and follow-up frequency is influenced by both exposure status and early signs of the outcome, then you can create a distorted comparison because you selected on a variable affected by both sides. Another example, if you analyze only people who were hospitalized, and hospitalization is influenced by exposure and outcome risk, the relationship between exposure and outcome within hospitalized people may not reflect the relationship in the full population. This is why covariate selection is not just include more variables. Including the wrong variables can be worse than including fewer. A practical approach to covariate selection starts with thinking about time order and what variables exist before exposure. Covariates used for confounding adjustment, ASH, should typically be measured before the exposure or intervention because they represent baseline differences rather than consequences of exposure. For example, age, baseline condition severity, prior history, and baseline access indicators often qualify as pre-exposure covariates. Another example, baseline performance metrics and pre-intervention trends can be important covariates when evaluating policy or program changes. In contrast, variables measured after exposure begins are more likely to be mediators or colliders, which require caution. This time-based thinking is one of the simplest ways to avoid overadjustment. When in doubt, prefer baseline covariates rather than post-exposure variables, unless there is a clear reason and a clear interpretation. Another practical approach is to define a minimal sufficient adjustment set, the smallest set of covariates needed to address major confounding / without introducing new bias. The idea is not to control for everything, but to control for the right things. For example, if evaluating a treatment effect, important baseline confounders might include severity and comorbidities because they influence both treatment choice and outcomes. If evaluating a program that people opt into, important baseline confounders might include motivation proxies, prior engagement, baseline barriers, and baseline outcome level. If comparing regions, important confounders might include population age structure, socioeconomic indicators, and baseline access. Minimal sufficient sets are attractive because they reduce unnecessary complexity, improve interpretability, and often improve precision by avoiding noisy variables that do not help reduce bias. Covariate selection also depends on whether the goal is causal estimation, prediction, or description. For prediction, including many variables can be useful if they improve predictive accuracy, even if they are mediators, because the goal is forecasting rather than estimating an exposure effect. For causal estimation, including mediators can change the estimand, and including colliders can introduce bias, so selection is more constrained. For description, covariates may be used to stratify results rather than adjust them, such as reporting outcomes by age group or by baseline risk category. Multiple examples show the difference. A readmission prediction model can use post-discharge variables because it aims to predict risk, while a causal analysis of a discharge intervention should be careful about post-discharge variables that are affected by the intervention. A model predicting turnover might use intermediate indicators like satisfaction scores, while an analysis estimating the effect of a new management policy on turnover should be cautious if satisfaction is influenced by the policy. Finally, good covariate selection includes transparency and sensitivity checks. Transparency means documenting why each covariate was included and what role it is assumed to play. Sensitivity checks mean testing whether conclusions change when reasonable alternative covariate sets are used. For example, you might compare a model adjusted for a minimal set of key confounders versus a model with a broader set of baseline covariates to see if results are stable. Another example, you might test models with different severity proxies to see whether the exposure effect estimate changes substantially. Stability across reasonable choices increases confidence, while large shifts suggest results may be sensitive to modeling assumptions or residual confounding. Covariate selection is therefore both a scientific and a practical skill. It requires reasoning about how the world works and discipline in keeping the analysis aligned with the question. A conceptual model is a plain language map of how you believe the variables relate to each other in the real world before you run any statistics. It is a way to write down your assumptions so the analysis is guided by logic rather than by whatever the data happen to show. This matters because many statistical models can fit the same data set, and without a conceptual model, it becomes easy to adjust for the wrong variables, interpret associations as causes, or chase patterns that are mostly noise. A conceptual model does not need to be complicated. It can be a written narrative, a simple diagram, or a list of "this affects that" statements. The key is that it clarifies roles like exposure, outcome, confounders, mediators, and effect modifiers before modeling begins. A conceptual model forces clarity about the direction of influence and the timing of variables. This helps prevent common mistakes, like controlling for variables that occur after the exposure, or mixing up what came first. For example, if the exposure is a program and the outcome is a health improvement, the conceptual model might state that the program increases engagement, engagement increases follow-up, and follow-up increases improvement. That immediately suggests engagement and follow-up are potential mediators, meaning they are part of the pathway. Another example, if the exposure is a staffing change and the outcome is wait time, the model might state staffing affects capacity, capacity affects wait time, and wait time affects satisfaction. That helps separate what should be adjusted for, baseline differences, from what should be examined as part of the mechanism, capacity and wait time pathways. This kind of structure keeps the analysis aligned with the question and prevents accidental overadjustment. A conceptual model is also how you identify likely confounders and justify covariates. Confounders are variables that influence both exposure and outcome and can distort comparisons. By listing plausible causes of exposure and plausible causes of outcome, you can identify overlaps. For example, if people self-select into an intervention, motivation and resources may influence selection and also influence outcomes. Another example, if a certain service is more available in higher resource areas, area-level resources influence exposure to the service and also influence outcomes, which means resources are confounding the relationship. In clinical settings, baseline severity often influences treatment choice and outcomes. In operational settings, baseline workload can influence which process changes are adopted and also influence performance outcomes. Writing these relationships down makes covariate selection more defensible and less arbitrary. Conceptual models also help distinguish between explaining and predicting, which leads to different modeling choices. If the goal is prediction, the conceptual model is about what signals help forecast an outcome, even if those signals are intermediate factors. For example, predicting who will miss an appointment might reasonably use reminders sent, prior attendance patterns, and recent engagement. Predicting equipment failure might use vibration readings, recent maintenance logs, and operating hours. In contrast, if the goal is estimating the effect of an intervention, the conceptual model is about what should be controlled for to create a fair comparison and what should not be controlled for because it lies on the pathway. For example, If an intervention affects engagement and engagement affects outcomes, controlling for engagement changes the question from total effect to something closer to direct effect. The conceptual model keeps these goals separate, so the analysis does not unintentionally switch purposes. A practical advantage of conceptual models is that they guide how you handle measurement limitations. Real data rarely measure concepts perfectly, so you often rely on proxies. A conceptual model helps you decide whether a proxy is likely to capture the concept you need and what bias may remain. For example, if you want to adjust for socioeconomic status, but you only have insurance type or area level income, the model helps you recognize that adjustment is partial and that residual confounding may remain. Another example, if baseline severity is not directly measured, you might use prior utilization or prior diagnoses as proxies, and the model helps you explain that those proxies may not fully capture severity. In operations, if work complexity is not recorded, you might use task type or average handling time as a proxy, and the model helps identify what that proxy misses. This improves transparency and prevents overconfidence in adjusted models. Conceptual models also help plan subgroup and interaction analyses responsibly. If you believe an intervention works differently in different contexts, the conceptual model helps identify plausible effect modifiers and why they might modify the effect. For example, a program might be more effective in settings with strong staffing and follow-up capacity than in settings with limited capacity. Another example, a treatment might show different effectiveness by baseline risk level because high-risk individuals have more room for improvement. In workforce settings, a training program might show larger benefits for new staff than for experienced staff. The conceptual model helps you state these hypotheses clearly and avoid data-driven subgroup fishing, where many subgroups are tested without a prior rationale, increasing the chance of false positives. Finally, having a conceptual model makes your work easier to communicate and defend. It provides a clean explanation of why certain variables were adjusted for, why some variables were not adjusted for, and how you interpret results given the assumed relationships. For example, you can explain that baseline factors were adjusted for to reduce confounding, while intermediate variables were not adjusted for because they are part of the pathway, and adjusting would change the meaning of the estimate. Another example, you can explain why results might differ across sites because site-level context modifies implementation and therefore modifies effect. This type of explanation builds credibility with both technical and non-technical audiences because it shows the analysis is grounded in reasoning rather than a black box. Pre-specifying variables means deciding in advance which variables will be used for primary analyses, how they will be defined, and what role they will play. This is typically written into a protocol or an analysis plan. The purpose is to protect the credibility of results by reducing the chance that choices are influenced by what looks best after seeing the data. When variable choices are made after exploring results, it becomes easy to unintentionally optimize the analysis toward a desired conclusion, even if the analyst is acting in good faith. For example, if several outcome definitions exist and only the one that shows the strongest difference is reported, the result can be misleading. Another example, if several ways to define exposure intensity are tried and the most favorable threshold is selected, the apparent effect may be overstated and may not replicate. Pre-specification is especially important because most variables in real datasets can be defined multiple ways. Outcomes can have multiple time windows, different inclusion rules, and different thresholds. Exposures can be defined as any exposure, sustained exposure, high versus low exposure, or exposure dose over time. Covariates can be coded as continuous, categorical, or grouped in different ways. For example, follow-up within recommended time could be defined as within 7 days, 14 days, 30 days, or a guideline-specific window, and each choice yields a different rate. Another example, program participation could mean attended at least one session, completed a minimum number of sessions, completed all sessions, or completed a core component. Without pre-specification, it is easy to shift definitions until the results look convincing, which weakens trust. Pre-specifying variable roles also prevents mixing up confounders, mediators, and effect modifiers in a way that changes the meaning of the estimate. A protocol can specify which baseline covariates will be used for confounding adjustment and which post-exposure variables will be treated as intermediates rather than adjustment variables. For example, a protocol might state that baseline severity, baseline utilization, and baseline access indicators will be included as confounders, while follow-up engagement will be analyzed as a mediator pathway rather than controlled for in the primary model. Another example, a protocol might state that site-level staffing capacity will be tested as a potential effect modifier, meaning the effect may be reported separately or with interaction, rather than being buried in an average effect. Pre-specification makes the logic visible and reduces the chance that modeling becomes a trial-and-error search for a desired result. Pre-specification does not mean you cannot explore. It means you separate confirmatory analysis from exploratory analysis. Confirmatory analysis is the planned analysis tied to the primary question, and exploratory analysis is additional work used for learning, hypothesis generation, and refining future studies. Both are valuable, but they should be labeled and interpreted differently. For example, an exploratory analysis might test alternate outcome windows or additional subgroups to see whether patterns suggest new hypotheses. Another example, exploratory work might try different coding schemes for an exposure to see whether results are robust or whether there is evidence of a dose-response relationship. The key is that exploratory findings are treated as provisional and are ideally confirmed in new data, or with a pre-specified plan in the future. A practical protocol often includes a variable dictionary or table that lists each variable, its definition, its coding, and its intended role. This helps reduce confusion, especially when multiple people are involved or when a project runs over time. For example, it can specify how missing values will be handled for each variable, how categories will be collapsed when sparse, and what time window applies. Another example, it can specify that age will be treated as continuous with a spline, a flexible curve, or grouped into categories, and it can specify those categories explicitly. For outcomes, it can specify whether the outcome is measured once per person, per event, or per time period. These details might sound small, but they are often where inconsistencies creep in and where disagreements arise when results are audited or replicated. Pre-specifying variables also supports reproducibility and reduces errors. When variable definitions are written clearly, it becomes easier to write code that can be rerun and reviewed, and easier for another analyst to reproduce the dataset and results. For example, a protocol can specify that duplicate records will be resolved using a particular rule, that certain date ranges will be excluded, and that only the first qualifying event per person will be used for a specific endpoint. Another example, slide, it can specify that records must meet certain quality checks to be included, such as valid identifiers and plausible ranges. In operational analytics, where dashboards refresh regularly, pre-specification is the difference between consistent reporting and changing numbers that no one can explain. Finally, pre-specification strengthens communication because it makes it easier to explain SLACE, why the analysis should be trusted. It provides a defensible rationale for why the primary endpoint was chosen, why certain covariates were included, and why certain subgroups were examined. It also creates a clear structure for reporting deviations. Deviations are sometimes necessary because real data are messy, but they should be documented transparently, along with why the deviation was needed and how it might affect interpretation. This level of transparency builds confidence for leadership, reviewers, and partners. It also protects you professionally because your results are tied to a clear plan, rather than appearing to be a set of flexible choices made after seeing outcomes.